Assessment Abdomen Pediatric. An abdominal assessment is complex because of the multiple organs located in and near the abdominal cavity. By performing a thorough abdominal assessment, healthcare professionals can identify any abnormalities or changes in these organs that may indicate a health issue. Additionally, abdominal assessment can help diagnose conditions such as appendicitis, gallstones, and hernias. Perform hand hygiene and don gloves. Verify the correct child using 2 identifiers. If the child has abdominal or lower back pain, assess the character of the pain in detail, PQRST. Assess the child's normal bowel habits, such as frequency of stools, character of stools, recent changes in the character of stools, measures used to promote elimination, such as laxatives, enemas, and dietary intake, and eating and drinking habits. Assess the child's history of abdominal surgery, trauma, or diagnostic tests of the gastrointestinal (GI) tract. Determine whether the child is experiencing or has had any nausea, vomiting, or cramping. Assess for difficulty in swallowing, flatulence, bloody emesis, hematemesis, black or tarry stools, melena, reflux, diarrhea, or constipation. Determine whether the child takes drugs that may cause GI upset or bleeding. Inquire about a family history of cancer, kidney disease, hypertension, or heart disease. Assess the child's and family's understandings of the reasons for and the risks and benefits of an abdominal assessment. Ask the child if he or she needs to empty the bladder or defecate, if developmentally appropriate. Perform hand hygiene. Prepare the child. Have the child stand erect and then lie supine during the inspection of the abdominal surface. Place a pillow under the child's knees for comfort if needed. Expose the area from just above the xiphoid process down to the symphysis pubis. Maintain a developmentally appropriate conversation during the assessment, except during auscultation. Instruct the child to point to tender areas, if developmentally appropriate. Identify landmarks that divide the abdominal region into 4 equal quadrants. Inspect the skin of the abdomen surface for color, scars, venous patterns, rashes, lesions, silvery white striae, stretch marks, and artificial openings. Observe abnormal protrusions at the umbilicus or inguinal areas. Observe any lesion characteristics. Inspect the contour, symmetry, and surface motion of the abdomen. Note any masses, bulging, or distension. Inspect the umbilicus for hygiene and evidence of abnormalities. For the child, observe for hygiene and abnormal shape indicating hernia. For the infant, observe signs and symptoms of infection noted as redness, swelling, drainage, or foul odor. For the adolescent, inspect for hygiene and, if there are piercings, inspect for signs and symptoms of infection noted as redness or swelling. If the abdomen appears distended, perform the following steps. Assess whether the distension is generalized. Observe at the flanks on each side. Be aware that a paralytic ileus may be accompanied by nausea and vomiting, increasing distension, and inability to pass flatus. Measure abdominal girth by placing a tape measure around the abdomen at the level of the umbilicus. If a nasogastric or intestinal tube is connected to a suction device, turn it off while auscultating the abdomen. Auscultate bowel sounds by placing the diaphragm of the stethoscope lightly over each of the 4 abdominal quadrants. If developmentally appropriate, ask the child not to talk. Listen until repeated gurgling or bubbling sounds are heard in each quadrant. Describe sounds as normal, hyperactive, hypoactive, or absent. Normal bowel sounds typically occur every 5 to 15 seconds. Hypoactive bowel sounds might be heard every 1 to 2 minutes or less. Hyperactive bowel sounds usually heard more often than every 5 to 15 seconds. Listen for 5 minutes over each quadrant before deciding that bowel sounds are absent. Ask the child or a family member if the abdomen feels unusually tight and determine whether this is a recent development. Lightly palpate over each abdominal quadrant, laying the palm of the hand with fingers extended and approximated lightly on the abdomen. Keep the palm and forearm horizontal. With the pads of the fingertips, depress the skin approximately 1 centimeter, 3/8 inch, in a gentle dipping motion. A child may perceive superficial palpation as tickling. If appropriate, have the child help by placing one hand on top of yours, or have the child place one hand on his or her abdomen with fingers separated and palpate between the child's fingers. Note muscular resistance, distension, tenderness, and superficial masses or organs while observing the child's face for signs of discomfort. Note whether the abdomen is firm or soft to the touch. Palpate for a smooth, rounded mass just below the umbilicus and above the symphysis pubis. While applying light pressure, ask if the child has the sensation of needing to void, if developmentally appropriate. Routinely check for a distended bladder if the child has been unable to void, has been incontinent, or has an indwelling urinary catheter that is not draining well. If masses are palpated, note the size, location, shape, consistency, tenderness, mobility, and texture. When tenderness is present, press one hand slowly and deeply into the involved area and then let go quickly. Note whether pain is exacerbated. Perform deep palpation, ensuring that the child is relaxed. Palpate the abdomen below the right costal margin to palpate the lower edge of the liver. Report whether the liver is palpable 3 centimeters, 1¼ inches, below the right costal margin, or the spleen is palpable more than 2 centimeters, 3/4 inch, below the left costal margin. With the child sitting, gently but firmly percuss over each costovertebral angle. Use the ulnar surface of the first to percuss directly against the child's skin or indirectly by placing the non-dominant hand flat against the costovertebral angle and percuss with the dominant hand. Note whether the child experiences pain. If yes, assess, treat, and reassess pain. Perform hand hygiene. Document the procedure in the child's record.